development course. I want just a couple of housekeeping things here. This is new. We had to get special permission from the American College of Surgeons to do this. The Rural Trauma Team Development course is designed to be an individualized, in-person, hands-on course. So what we have done is we have visited the centers participating right now. We went and visited their emergency department, went through some questionnaires about what they have, the resources available to them, what constitutes a trauma team, et cetera. And we're going to speak specifically to those issues and point out individual differences as we go through the lecture, if there are any. So that's how we're going to try to make this work. We have done some videos in the simulation lab on the various aspects that we're going to be running. Now, I do want to say that these videos are for education only, okay? They are just to prove the concept of how a three-man team can work to take care of a trauma patient. And again, the EMS makes up a big part of the resources of a rural trauma center. So we will try to address some of those to the EMS as well. And remember, when they bring a patient in, you can always use them to help as an additional person on a complicated patient. And we'll go over that as we go through. So again, this is a rural trauma team development course. We're teaching the 4th edition right now. Okay, so the objectives are to increase awareness and challenges faced in the rural trauma environment. Define the components of a team. That's basically any two people working together. We'll go over all that. Define key elements for an effective team leadership and understand essential components of communication. As with most things in medicine, when things go wrong, almost always there's a communication issue, and we're going to go over that time and time again throughout this course. So what defines the rural trauma environment? Basically, when optimal care of the injured patient is delayed or limited by geography, weather, distance, resources, or lack of experience. And that's pretty obvious when you're in the middle of nowhere or in the middle of a snowstorm, but sometimes places that you wouldn't think can become like a rural trauma environment. For instance, Manhattan, when a plane flies into 2 towers and the bridges are congested and people can't get in and out, and the power goes out, like in Hurricane Katrina, in the major hospitals, and then smaller hospitals are forced to take care of these patients. So it's really, not where you are, but the limitation of resources, transportation, et cetera, that defines whether you're treating a patient in an austere condition or not. And these are some basic concepts. In 2013, it says approximately 20% of the US population lived in rural areas, but accounted for 54 to 60% of all fatalities. And really the fatality rate in the rural environment is 2.6 times higher than that in urban environments. And actually, if you really get down to brass tacks, you're about 40 times more likely to die of survivable injuries in the rural environment as compared to the urban environment. Not because of the quality of care, but because of the limitations of that environment in terms of identification, transport, and time. Time is not our friend when it comes to high acuity trauma. And again, delays in various phases of care of the patient are why patients die of survivable injuries compared to patients in urban areas, which have fewer delays. And what are these delays? Discovery. If you're in a remote area, it may be an hour before someone drives by to realize that there's a car off the road. And then they have to call for help. Help has to arrive. Then they have to extricate and take you to the closest facility or the closest trauma center. Sometimes the scene time can be prolonged if you're deep in the woods and need to have a utility vehicle or whatever to bring you out. And then many times the distance between the rural trauma centers and the level 1s or level 2s is significant. So all this equates to time. And remember, in a trauma patient, the time that their clock starts is the time of their injury, not the time that we identify the patient or lay hands on the patient. So we may be past that golden hour way before the patient's even identified off the side of the road. And then when they get to the trauma center or the rural trauma hospital or the critical access hospital, there's delays in identification of immediately life-threatening injuries, not because of the quality of the physicians and nursing care at the hospital, but just simply because they don't do it as often as the trauma center. So it takes them a little bit longer to get down the algorithm. And then because when patients come in with multiple injuries, prioritization of those injuries is more difficult if you don't do them on a regular basis. Recognizing a severely injured patient and transporting to a higher level of care. Again, all of these delays are just built into the fact that small centers don't do a lot of this, and preparation is key. But preparation only goes so far. Really, it's practice, 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 but not perfect practice every time that gives you perfect results. So the Rural Trauma Team Development course was developed to improve the care and outcome of rural trauma patients by teaching a team approach in the assessment of resuscitation at a facility that is an austere environment where rapid transport to definitive care may not be so rapid. And the patient's care exceeds the capability of the local facility, not in terms of physicians or nursing, but just resources. May not have neurosurgeon, orthopedist, et cetera, that can take care of these patients. And really, this course has done what what we've tried to do for many, many years. The focus is not on the trauma center. It's on the people out in the field who are identifying, extricating, and initially stabilizing these patients, rendering point of care to the injuries sustained, such as stopping bleeding, airway stabilization, that kind of stuff. We've tried to do this for years. It seems like the trauma centers, always get all the glory, but really, what I tell people all the time, if you bring me a dead patient, I will just simply be left with a dead patient. I can't do anything unless you do the job in the pre-hospital phase as well as you can. You make the difference. And that difference comes because you're interested and you have some basic knowledge to initially stabilize these complex patients. We did this many years ago in the 1960s with advanced cardiac life support and basic cardiac life support. We took what used to be just an ICU procedure of CPR to the streets and found a significant improvement in survival. Well, we need to do the same thing with basic trauma care, stopping the bleeding, hemorrhage control, airway stabilization. And when we can bring basic pre-hospital trauma life support to the lay person who is the first responder many times, just like BLS, CPR, we're going to see significant improvements in overall trauma survival. And what you do makes a difference. There's no question about that. The team should, now one of the goals is the team should determine within 15 minutes of the patient's arrival or hearing about the patient that it's going to exceed the resources of your facility and initiate the transfer process. Getting the patient to a definitive care center is one of the biggest goals on a severely injured multi-trauma patient. And in order to do this, you need to know when your resources are exceeded, and there's no ego when it comes to trauma. I mean, you could put me out in Fulton County or Meyersdale, and I would probably be able to do, I don't know, probably not even as good a job as the people out there because they know their resources. But I can't do a thoracotomy and transfuse 16, 18 units of blood plasma and platelets at a rural facility because they don't have those resources. So that's the limitation, not the quality of the care. Don't delay the transfer of definitive diagnosis. You don't need to know all the injuries. Just you need to know that the patient is too sick to be at your facility and needs to be somewhere else, and stabilize what you can and realize that those things that you can't, such as a bleeding spleen, if you don't have blood and you don't have a surgeon, there's not a lot you can do about that except get the patient to the definitive care center as quickly as possible. And again, what defines a team? Any two or more people working together that have a shared mental model, have specific goals and roles to play in the trauma resuscitation. And those roles need to be predetermined, and people need to know what their overall end game is. It's to basically quickly stabilize the patient and identify potential life-threatening injuries that may exceed your capability and get them to a definitive care center as quickly as possible. Obviously, if it's just a broken ankle with no other injuries, that may be something that you can take care of there, but that you have to quickly get through that algorithm and make that determination quickly. And according to the American College of Surgeons, I mean, we feel, or they feel, that most small places can muster at least a 3-man team. And that's what this course is designed around. 3 people with a team leader and 2 team members and appropriate roles based on their clinical abilities. So when you're thinking about your facility, okay, not what we do at Conemaugh or what Altoona does, UPMC Altoona does, or any of those places, what can you do in your facility? Have a preset plan. Know when a patient comes in, is this a trauma or not? Do I need extra help or not? And how do I mobilize that extra help, i.e. a trauma activation of some kind? And then a standardized approach. Where do they go? Where's the basic equipment, and who's going to lead this team, and who's going to make the calls? Do you have a transfer agreement with ambulance companies and hospitals, and how do you initiate that process? That needs to be laid out up front. Most facilities can mobilize at least 3 people at any given time, and that's how we're going to go over most of this course. But specifically, what is your plan? And what are your resources? Now, the 4 hospitals that we visited last week all have detailed triage criteria based on American College of Surgeons criteria. They have team members for their specific emergency rooms. And most of them have a physician, a nurse or 2 nurses, and a technician or a non-clinical person who can help. And all of them have the EMS people who initially bring the patient in and can be basically retained for their medical expertise and skills if needed. So basically have a preset plan and standard approach. Let people know what the roles are. Now, if you're working with different people before the patient gets there, you need to tell everyone what their roles are. But if you have a team that's pretty standard, and always a nurse and always a clinical person or a non-clinical person, a lab tech or radiology tech, or even a nursing supervisor that comes down from the floor, they should know when a trauma comes in, this is what I'm going to do. If one is going to be placing monitors, IVs, we'll go over all that. The other one's going to be recording, making phone calls, getting extra equipment as needed. This needs to be done ahead of time, because the worst time to try to make these kinds of assignments is when you're in the middle of the storm. And so that when a sick patient comes in, everyone's ready. In trauma, we say we prepare for the sick 10%. 80 to 90% of the time people come in and they can be easily managed with minimal resources, but we have to prepare for that 10% of people that come in bad, hurt, and sick. And basically everything that we do is one step closer to saving a life, a limb, or eyesight, that kind of thing. So your trauma plan needs to include what's going to constitute a trauma activation. I mean, and that's going to depend on the size of your facility. The 4 facilities that we visited are all very similar in size. And basically anything that comes in that's going to need more than just a cursory evaluation when it comes to trauma is probably going to require trauma activation. You have to have a system that's reliable. How do you get your people mobilized? For the most part, in these small facilities, they're all sitting around in the same area or literally across the hall. So a verbal or over the head typically works well for them, and that seems to be what most people have, and that is very usable. The trauma evaluation resuscitation protocol is basically ACLS run by a three-man team. The trauma flow sheets, everyone has one that we visited. They are all a little bit different, but they basically just have to document the story of how that patient was taken care of, what was done for that patient, so that when the patient is transferred, we know what was done, what to look for, and what else needs to be done. Treatment protocols, everyone has their basic protocols. For instance, massive transfusion protocols, administration of TXA, all those things exist in all the facilities that we facilitated. The MTPs will be different because some places have blood cells, but they don't have plasma. Some places have blood and plasma, but none of the places that we visited have any excess platelets at this time. So their protocols are all going to be different, and transfer criteria need to be determined ahead of time in terms of what patients you can adequately take care of and not, and which ones you're going to transfer. But remember, it's not only the identified injuries that define this, it's the potential injuries based on the mechanism. So someone, on anticoagulation who lost consciousness, who basically may have a head injury, and yet you don't have a neurosurgeon, that you technically could keep that patient. But what if they deteriorate? What if the small subarachnoid becomes a large bleed? So you have to prepare for that. It's the potential injuries as much as the identified injuries that necessitate the transfer. So the 3-member team, and again, throughout this whole course, this will be in all of the lectures. We may not dwell on it each time because it does not change. The team leader is going to be the physician, nurse practitioner, or the PA that's in the emergency department at that time. Team member 1 is technically the next most skilled clinical person, such as the nurse or the pre-hospital provider. Team number 2 can be the next step down in terms of someone who has less clinical expertise, but it can include a nurse or the pre-hospital provider if you're lucky enough to have 2 of them, or someone like a radiology tech, a clerk, or anybody that you can lay your hands on who simply can make phone calls, document things, and run and get equipment as long as they know where that equipment is beforehand. And that's where the preparation comes into play, because you literally can't send someone to get a chest tube if they don't even know what a chest tube is or what it looks like. So the team leader must organize a team, articulate the plan, assign the appropriate responsibilities, usually before the trauma patient gets there, if at all possible, or even as a predetermined plan that these are the tasks for the people that are going to be participating in this trauma team. And then adapt that plan or modify the roles based on the changes in situations. Someone may have called off, you may be down a person, you have to be flexible, you have to adapt and overcome and take care of the patient. So this is the rule of medicine and trauma. Nothing is ever as you plan for, right? It's always going to be different, or you're not going to have what you need at the time, or something's going to work, the power goes out or something like that. You just have to plan for it. The team leader is going to direct the resuscitation. Now, this is where, when we're teaching ATLS at a trauma center, the team leader is typically the conductor of the orchestra. They're going to stand back and watch the big picture and tell everyone what else to do. But in a small facility, you don't have that luxury. Your team leader is going to be the most clinically experienced person in the room, and they're going to have to perform the primary and secondary survey as well as direct the resuscitation. They may have to perform the more advanced procedures such as intubation, chest tube insertion, needle thoracostomy of the chest, that kind of stuff. So they're going to be actively involved in the resuscitation itself as well as directing the overall resuscitation. But they still have to maintain situational awareness in terms of, what's the saturation doing, what's the blood pressure doing, what's the heart rate doing, how many units of blood have been given, if they've been given at all. And this requires excellent communication, because other people are going to be doing these things, and it has to be clearly communicated back and forth as to where we are in this phase of resuscitation and what's been done for the patient. And again, this type of team has to empower everybody in the team to be an active participant. So if you see something, you say something. Hey, the blood pressure is dropping. Don't be afraid to speak up when it comes to basically taking care of the patient. And everybody has to be cognizant of those requirements. Everybody in that team has a significant role, and everyone has something to say, and you need to listen to each other. You need to basically brief what's going to happen. So if you have time before the patient gets there, get your team together and go over, hey, this is who you're going to do this, and this, and you're going to do the other things, and clarify that we quickly, need to identify, within 15 minutes, I want to know where this patient is going. And it sounds like this may be an airway issue. We need to make sure the airway is taken care of before we do anything else. Or if the patient has catastrophic bleeding, the first thing we're going to do is get some quick clot pressure, tourniquet, or whatever on to control the catastrophic bleeding, and then we're going to go ahead and on with resuscitation. After you've done that, you're going to get together and talk about what we found, what needs to be done for the patient. And then after the patient leaves, talk about what happened, and can we do it better? And did we catch all the key things that we should have done? Because as much as you practice, there's always going to be something, oh, I forgot to take a temperature, or, oh, you know what, we didn't run warm fluid. We ran, basically the fluid from the shelf, that kind of stuff. No matter how good we do or how good a resuscitation does, it can always be better for the next patient if we sit down, break it down, and then talk about what we could do better, faster, or differently. So as a team member, you need to know your role. Communication is key. If I say, hey, Mike, I need a unit of blood hung. I'm going to be looking at the patient and assessing the patient. Mike's going to say, hey, unit of blood is hung. It's running right now. So I know that that's going on. Otherwise, I'm going to assume it's happened. Or if I just say, hey, I need a unit of blood, everyone thinks it's someone else I'm talking to, and the blood never gets hung. So clear communication, report tasks when they're completed. And you can say, yes, I'm going to go get the blood right now. Verbalize these things so that people know what's going on. And again, communication. That's the key when it comes to working efficiently in teams, be they large or small. Team member one, this is going to be probably the nurse. They're very skilled at obtaining IV access, putting monitors on, giving medication. And if necessary, they can assist in performing some of the procedures, such as putting the tube in, tube thoracostomy, or applying tourniquets, T-pods, that kind of things, and dressing the wounds. This is a typical role of the next most experienced role in the of a team member. Team member two may not even be a clinical person. They may just be the clerk sitting at the front desk or the chaplain that may be there. You're going to use them for documentation, following the vital signs, reporting them out, whatever. So you can tell me the vital signs every 5 minutes or whatever. Communication with internal and external resources, such as your ambulance companies, helicopter companies, or the referring trauma center. They'll be running and getting things that aren't immediately available in your rooms. Now, the places that we visited, their supplies are actually, these facilities are actually well prepared. All of them, their supplies are either in the room or literally right next door. So you're not going to have to run very far to get the things that aren't actually in the room. So I was very impressed with the preparation and the resources available in the immediate resuscitation areas of these 4 facilities that we've visited. Prepares documentation for transfer and other tasks as needed by the team. This is not a derogatory thing, but I call this the gopher person, the person who's available to get everything else that we need when all of our other hands are tied up. Preparation is the name of the game. Alexander Graham Bell said it best when he said preparation is key to above all else, preparation is the key. So preparation makes the difference between, basically a routine assessment of a badly injured patient and a chaotic disaster, and a patient coming in with everyone doing their own thing and knowing what to do. And have appropriate equipment ready and checked. So know where your airway management is. Know where your chest tube equipment is. IV access and warm fluids. What fluids are you going to use? Know where all the places actually were really nice. They had hemorrhage control carts or boxes that had the quick clot and, the tourniquet and all that stuff in there. And then, for some of us who don't do a lot of pediatric trauma, knowing exactly where the pediatric cart is and the Breslow tape, which we'll talk about that later. So know where your equipment is. So that when you ask for it, people know exactly where to go get it. And communication, again, is when something goes wrong, many times communication is really at the heart of it. Each person needs to know what their roles are, and they need to communicate clearly when things are done. Monitors are on, saturation is this, IV is obtained, or I can't get an IV access, where are we going? And why can this be difficult? Because it's a noisy environment. There are other things going on in the emergency department. Sometimes you don't have all the information that you need. People, the perception of their role may be difficult, or they just don't feel, I can't say anything because I'm just the clerk. You know, they can see the blood pressure dropping. They need to be able to speak up. So this is, these are 2 videos done by the American College of Surgeons, and you'll be able to see, you know, where communication fails.
We're transporting a 35-year-old female, high-speed motor vehicle crash. She's unresponsive, and we're about 10 minutes out.
Okay, arrival in 10 minutes. 1 patient, MVC, arrival in 10 minutes. Okay.
You hear anything about what's coming in?
No.
Okay.
Do I need to mute myself?
Yeah, go. Watch your legs.
Let me get that.
All
Wait,
right.
wait.
All right, this is a 35-year-old female. She was involved in a high-speed MVA. Initially, she was wake alert oriented. Throughout transport, her mental status has decreased. I now got a GCS of 9. Vitals, BP 120/80. She was tachycardic 124. Sinus tach on the monitor. She's 100% with O2. She had a deformity in the right upper thigh. We went ahead and put the traction splint on her. Had good pulses before and after. Nothing else really noted during our exam. We had about a 10-minute transport in. You want to know anything else?
What did you say our BP was?
120/80.
Ma'am, I'm just gonna take a temperature under your tongue.
Ma'am, can you tell me your name? Ma'am, can you tell me your name? Can you see my hand? Ma'am, can you wiggle your toes?
120/80, heart rate 180.
Ma'am, can you tell me your name? Can you wiggle your toes? Okay, she's just moaning. She's not really moving anything. I think we might need to intubate. We'll need some etomidate and some sucks. Can somebody call up to X-ray and call for another nurse, please? And let Dr. Sidwell know too.
Read that.
Paramedic just sent me some pictures from the wreck scene.
That's her?
Yeah, so what can I do?
If you don't mind getting X-ray and labs.
Sam, can you tell me your name? Did somebody let Dr. Sidwell know?
Oh, I'm here. What's the situation? What's going on?
A 35-year-old high-speed MVC. She's not really responsive. She's moaning.
Wow.
I think we might need to intubate.
Wow, I wish you would have let me know sooner. Okay, let's get her taken care of. You're right, I think she needs to be intubated. She's going to need some medicine for this. What I'll do, I'll help hold her,
Okay.
So can someone else?
Anthony, while you get her intubated.
Okay.
So, first though, we're going to give her some medicine.
1 second.
Okay, does that thing work?
What do you want to do?
That thing works. Let's give her some etomidate and some succinylcholine. And then you'll get her intubated while I'm holding her steady.
Okay.
Medicines are in. Okay, let's take a look. Can you see anything?
It's pretty bloody. I'm probably going to need some
How about-
suction.
Yeah, some suction. Thanks for that. Go ahead, suck in there. Good. Are you able to see?
Still not seeing much.
Okay, here, let me take a look. I'll take a look. I'll take this thing. And maybe, do we have one of those bougies? I might need that.
Okay, I've got that out.
Okay, let me have that bougie. Yeah, I can see just a little bit here. Let me see. Okay. Okay, that's in. That's in. That's in. Okay, that's in the tube. So, yeah, thanks. Here, can you do that for me? Okay. I'm going to hold this. Go ahead and advance that in. Okay, good. I'll take this. Go ahead. We need to inflate her cuff. And then we need to check the untitled CO2. Where is it? That's the color. Is it over there? Okay, good. Grab that. And go ahead and get the bag for me. We'll do this. We'll listen to breath sounds as we do this. And, okay, go ahead. There. Okay, the color changes.
Good bilateral breath sounds.
Okay, so we have good breath sounds, the color changed, so our tube is in place. I'm gonna let someone secure this. And have we called the trauma center yet? She's going to have to be transferred. Have we called the trauma center?
Well, I was gonna do it, but which one do you want?
The one with the helicopter. Call the trauma center with the helicopter. And then we'll need x-ray, and let's recycle her vital signs.
Blood pressure 80 over 30, heart rate 135.
80, blood pressure 80.
She's on meters. This is number 4.
She might need some blood.
She might.
She might need some blood. So we're going to need lab, and we're going to need blood. I want you to finish looking her over. I'm going to work on talking with the trauma center. Okay?
Hello, trauma center.
Okay, yeah. Hi. So we've got this 35-year-old woman. She was a pedestrian struck by a car, and when she got to us, she wasn't very responsive, and so we got her intubated. And then initially her heart rate was 120 and her blood pressure was okay, but then her blood pressure went down, and so we've given her some fluid and we're getting ready to start some blood. And I think she has a femur fracture, so we've got a splint put on her femur fracture. Yeah, she needs more than us. We need to get her transferred to
Okay,
it.
so what does this head CT show?
CT head, no. That's, you guys always tell us not to do that. Why would you even ask me that? No, we did not do a head CT.
Okay, well, what else? I mean, like, you guys never worked these patients up right, so I assume you gave them a bunch of fluid, too?
Fluid, yes. So she's had 3 or 4 liters of fluid. She seems to be responding. We're getting ready to start. You know, you're making this really a hassle. Why does it have to be so hard? All we want to do is get her transferred because she needs more than we can provide her. If you're not going to take her, then I need to give another trauma center a call.
Yeah, fine. Yeah, no, go ahead. Just send her. That's fine. We'll take care of it.
Oh, okay, thanks.
So I think most of us would agree that there was some failure of communication in many instances there, okay? So we're going to show you another version. Can you hear me? We're going to show you another version of what would be improved communication. I think you'll see an obvious difference.
We're transporting a 35-year-old female, high-speed motor vehicle crash. She's unresponsive, and we're about 10 minutes out.
Okay, unresponsive female after MVC, full trauma team activation, arrival in 10 minutes. Full trauma team activation, 35-year-old female, unresponsive.
Okay. Can you call upstairs, let Dr. Sidwell know, call x-ray, let the lab know, and we need an extra nurse down here as well.
Okay, I'm getting an extra nurse, calling Dr. Sidwell, calling x-ray and the labs, and I'll activate the pagers.
Okay, thank you.
And I'll get intubation meds and get the room ready.
All right, and I'll get the intubation tray and meet you there.
Okay. What should I do?
And when the patient gets here, get them on the monitor, get a blood pressure, and start drawing some labs.
Okay, blood pressure, monitor labs.
Yes.
And I'll do intubation meds and assisting with procedures.
Okay, what's the situation?
All we know so far, 35-year-old female, high-speed MVC.
Okay, who's doing what? Kathy?
Blood pressure, monitoring labs.
Abby?
And I'll do intubation meds and assisting with procedures.
Bethany?
I'll get a primary and secondary survey.
Okay, do you know if we've called x-ray yet?
I've done that.
Okay, is all the equipment ready?
It is ready.
Then I think that we're ready. They should be here soon.
All right.
I'm gonna get my gloves on.
Thank you.
And are we good to go here? Okay, I think that we're ready for them. They're here. Great. Hi, folks. What's the situation?
35-year-old female. She was involved in a high-speed MVA. She was initially wake alert oriented, became disoriented during transport. Now has a GCS of 9. Her vitals are stable, 120/80. She was tachycardic 124, sinus tach on the monitor, 100% with non-breather on. She had upper right thigh deformity. We went ahead and put the traction splint on her. Good distal pulses before and after splinting. Do you have any other questions for me?
No, that's a real good report. Let's move her over. We're going to do this on the count of 3.
Everybody ready? On 3. 1, 2, 3. Ma'am, can you say your name? Ma'am. Airway is patent.
Do you hear breath sounds?
Breath sounds are equal but shallow.
Okay. Carotid pulses.
We have a strong carotid pulse.
Okay, what are her initial vital signs?
Her blood pressure is 110/60 and her heart rate's 120.
Okay, she has a patent airway. She has breath sounds on both sides. I'm worried that she's in shock because she's tachycardic. Well, what about disability? What is her GCS?
Ma'am, can you say your name? She's withdrawing to pain. GCS of 8.
GCS of 8. She's somebody that we're going to need to get intubated.
Okay.
Do we have our stuff?
So ready and checked intubation tray?
And she's someone that we are going to need to transfer. Hey, Veronica, could you begin working on the transfer process for us, please? Okay. Let's work on getting her intubated.
Okay, I have the intubation meds. I have etomidate and sucks, and she weighs 8 kgs.
Okay, we will want her to get then 24 milligrams of the etomidate
Okay.
and 80 milligrams of the succinylcholine. Don't give that yet until we're ready.
Okay.
Are we all okay with our supplies?
Just checked everything. We are ready.
Okay, then let's go ahead and give our medications. Start with the etomidate.
24 milligrams of etomidate. 80 milligrams of sucks given.
Okay, and the medications are in. She's relaxed. Let's go ahead with the intubation. Okay, are you able to see?
I cannot see the cords. It's a little bit bloody. If I could get some suction, that would be great. Okay, I see the cords.
See that go through the
It's going
cords?
through the cords.
Good, let's go remove the stylet and inflate the cuff. Let's
Cuff
hook
is
up-
inflated.
Let's hook up the color change.
Listen to breath
And-
sounds for us, Abby.
Abby will listen to breath sounds.
I have a good color change.
Good color change.
Good breath sounds.
We have good breath sounds. So our airway is secured. I'm going to replace her collar. Now, when x-ray is here, I'm going to need a chest x-ray. I'm going to want a pelvis x-ray. And then we need another set of vital signs, please.
The transfer protocol has been activated. The helicopter will be here in 15 minutes.
In 15 minutes. Okay, very good.
Her blood pressure has dropped to 85/58.
Okay, wow. So she's become hypotensive now. I'm going to want her to get a unit of blood, please. And then I want you to start finish this primary survey and then start a secondary survey.
Could you clarify that blood order, please?
Oh, I'm sorry, a unit of the emergency release blood, please.
And x-rays here.
X-ray is here.
1 unit of emergency release blood's been ordered.
Okay, thank you. So long as they're here, why don't we get a chest x-ray and a pelvis, and we'll get the femur and her fib, and why don't we get a forearm x-ray also, please?
Okay, I'm kind of afraid that we're gonna expose her to too much cold if we do all those films, so maybe we should get some vital signs and airway, like check the airway before we transfer
Good
her.
thinking, thank you. We'll just do the chest x-ray and the pelvis x-ray, finish up the primary survey. I'm going to go out and start talking to the transfer center to update them.
All right, that's good.
Let's get a blanket in here. She's pretty exposed right now, guys.
I'll get it.
Trauma Center, this is Dr. Dennis. How can we help you?
Hello, hi, this is Dr. Sidwell. Yeah, I have a 35-year-old woman. She was involved in a high-speed motor vehicle crash. When she arrived, she was tachycardic with a heart rate of 120, but she was normotensive. She had an initial GCS of 8, and so we have her intubated. That intubation proceeded uneventfully. After the intubation, she then became hypotensive, and so we started some fluid, and we started a unit of O-negative blood. She seems to be responding to that. I'm suspicious that she has chest injuries and a pelvic fracture and a right femur fracture, and in fact, I have the right femur splinted.
Sure.
She's someone that she needs more than we can handle, and we'd like to get her transferred.
So you have a young female, high-speed mechanism. Her airway is now secured. She's comatose, and with intermittent hypotension. You suspect chest, pelvis, and extremity injuries, and you're giving her blood. Do you guys have a fast there?
No, I haven't done an ultrasound. We don't have that equipment, and I wouldn't be able to do anything about it anyway.
Okay, sure, no problem. Yeah, thanks for the update. We'll be ready for her when she gets here.
Okay, that's great. Thank you for the help.
All right, thank you. Bye-bye.
So again, remember, I think we can all agree that there's a big difference between the two, and communication is why the resuscitations looked so good versus so bad initially, right? Again, the components of communication, where you're getting the message from, the data that needs to be confirmed, and basically you saw a lot of the nonverbal stuff. You could tell in the first video, people just weren't paying attention. They were disinterested. There was no sense of urgency, that kind of stuff. And we, in some of the videos, you'll see this thing called DMIS. That's the communication tool that we've been utilizing in our region. This is very similar, this Sir-Miser. It includes the same thing. So what do you need to convey with a seriously injured patient? The vital signs, injuries, response to treatment, mechanism of injury, injuries, vital signs, environment, response to treatment, or the DMIS, the demographics, patient age, sex, basically the mechanism of injury, the injuries you suspect, the vital signs, and then how the treatments that you've rendered and how they've responded to them. And we'll go over that in the scenarios. The language of ACLS or ATLS is airway, breathing, circulation, disability, exposure. It's been like that since its inception. The only change that we've added currently is CABCDE. So control catastrophic bleeding. If the blood is hitting the ceiling and dripping down on you, put a finger on it, then assess the airway type of thing. So hemorrhage control is paramount, especially when your resources are limited, because everything that you lose, you have to replace. And if you don't have any blood to replace it, it's better not to lose it, right? Was the message heard and understood? And the first one, you couldn't tell who you were speaking to, if anyone was listening to you, and if any of the orders that you were given were being called out. So call it out and then check back. What is the airway? Airway is patent. Instead of saying, I need a unit of blood, Jack, will you get me a unit of blood? Going for the unit of blood is hung, unit of blood is running, that kind of stuff. Communication is key. Seems simple, but when you're focused on trying to get an airway or putting a tube in, that's your whole world at that time. You don't recognize other things that may be going on at that time. External noise in the room is basically can overwhelm you. Overhead pagers, monitors, beeps, and everything else. Internal noise, personal conflict. I'm not sure that I should speak up. I mean, he's been mean to me so many times, I don't want to say anything. Or other things that are going on, or just the fact that you've been up all night and haven't eaten, and you're so concerned that, that I haven't eaten, et cetera. All these things get in the way of appropriate, effective communication. We just need to realize those things. Once we recognize them, they're fairly simple to overcome. The other thing is you don't speak in a condescending way to anyone. Your team is your team. They're vital components of the machine that's running right now. If you don't have one of them, you can't be effective. If one of them isn't paying attention or participating, you can't be effective. You may give an order and someone will say like, hey, I'm concerned that that's too much for this patient right now. Then you need to consider what they're saying and say, no, this needs to be done, or yes, you're right, like they did in the video. Let's not do all that. Let's just do what we need to do right now. Consider all the options, no matter where they come from. And hostility is not your friend. I mean, this is a cooperative environment. Everyone has to play together in order for the patient to do well. There is no ego. There should be no conflict. And when everything is said and done, everyone will have had a hand in making this patient do either well and getting them out effectively or not. The more critical situation, the more simple the communication has to be. You know, this is, if you have a really bad trauma in a trauma center, the bad trauma, there's almost no talking in the room. Only those people who need to speak and listen and call back are talking at the time. Time-sensitive issues require things to be done one time and effectively one time. You can't be calling out this, where's the unit of blood? Where's the unit of blood? Oh, I thought Jack went. No, I thought Jill went to get it. You know, everyone needs to know clearly who's getting the command and when the task is completed. And again, communication is a task that is highest risk of failure. We tend not to communicate effectively, especially when you don't know the people you're working with and no one knows what their roles are. I talked about this. And in communication, again, the big pitfalls, lack of defined roles and protocols, lack of knowledge or shared mental model, ineffective teamwork, people who haven't worked together or can't work together for one reason or another. And the biggest one is breakdown of communication, not communicating effectively. I mean, it really is the key to almost all evil in medicine is lack of communication. And at this point,
if they have any questions, go ahead and put them into the text box, and then the next one will be questions from you.
Okay. Again, this is new. You know, we're doing this virtually and online. So these questions you may or may see again at some place. So I would take note of the questions. Okay. So when an injury occurs in a rural environment, there are many things that may cause a delay in the patient's receiving definitive care. These delays result in increase in preventable mortality and morbidity. Which of the following is not a potential delay that should be minimized in the rural environment? So A, delay in identification of immediately life-threatening injuries. B, delay in treatment prioritization of potentially life-threatening injuries. C, delay in response time of the urban referral center. And D, delay in transport to a higher level care.
We'll go ahead and close the polling at this time. It looks like a lot of people have chosen C as the primary, actually 57%.
Most people answered C, delay in response time of the urban referral. Again, that may be a factor, but it's not a factor that you can minimize in the rural environment. You know, delay identification of immediately life-threatening injuries comes with pre-planning and working together and you know, talking about trauma injuries. Prioritization of life-threatening injuries is part of ATLS. And then delay in transport of higher level of care. This is the one we deal with mostly. And one of the big things is, you know, taking too long to evaluate a patient so that you can know all of the potential injuries that you can't do anything about in your facility. So this is one that we'll talk about throughout the course. There we go. 65-year-old woman is being brought to the emergency department of a rural facility by EMS following a fall down a flight of stairs. Upon arrival, she has a seizure and then becomes unresponsive. The most effective, to be most effective, the team leader in this situation must do all of the following except assign tasks and responsibilities, B, articulate the plan, C, personally execute all aspects of the plan, and D, adapt the plan on changes in the situation.
Okay, so go ahead and select your answer. Majority of the answers were C. Go ahead and close that.
So the correct answer in this case is C. The whole purpose of a team is so that everyone has a role and one person is not doing everything. But the team leader will assign the tasks and responsibilities if they haven't been pre-assigned already. They'll talk about the plan based on what the pre-hospital information is, and they'll adapt that plan based on changes in the situation. But they can't possibly execute everything, otherwise you would just need one person to do the whole assessment. Okay, last question. A 2-year-old, 13-kilogram girl is in the ED following a fall from a second-story window. She has normal vital signs appropriate for the age, but has obvious deformities of both forearms. Prior to reducing and splitting these fractures, a team leader has asked that the patient be given 4 milligrams of morphine and 2 milligrams of midazolam intravenously. The nurse is concerned that these amounts may be too much medication. The nurse should A, give the medication as ordered and carefully monitor the patient's response. B, clearly articulate the concern to the team leader in a respectful fashion. C, report the medication error to the new nursing supervisor. D, secretly give half of the ordered amount and observe the patient's response. And again, everybody, 100% is answered B again, and that's the whole purpose of this talk, was clear communication and empowering everybody in the team to play their part effectively. So the answer is B. And again, key points, effective team leader defines the roles, sets the tone of the resuscitation, maintains situational awareness, and communicates clearly. Facility preparation is key, knowing where your equipment is, and the people need to know where that equipment is. Any predefined protocols need to be discussed and rehearsed before the first trauma patient gets there. Communication is again, the root of all evil if it doesn't happen correctly. And everyone needs to be talking the same language. They need to understand what you're saying. If you're using words like, I don't know, like a chest tube. I mean, some people don't know what that is. You need to make sure that people understand what you're talking about.
EMS just called into the radio. There is a 25-year-old female motor vehicle accident, ETA 3 minutes.
Well, it sounds like we may have a trauma here. Pam, can you activate our trauma alert?
Activating trauma alert.
Why don't you guys go ahead and get your PPE on, and let's get ready. Pam, on this one, I want you to make sure that the patient has IV access. If they don't, try to get me an 18-gauge IV, and if we have some warm lactated ringers or saline, I'd like that to be running. Okay.
Okay.
Jody,
Have a standard razor.
well, let's just see how the patient is right now. Just get the IV, and if they don't need fluid, we won't get it. Jody, I'd like you to make sure that she's got oxygen on and get the pulse ox and the monitors on, and we'll go from there based on what she has.
Hi, this is Shantara, and she's awake.
Hi, Shantara. I'm Dr. Dumire. Can you hear me okay? Are you breathing okay?
Yes.
Okay. Jill, can you give us a report, please?
25-year-old female unrestrained into small car into a tree, initially unresponsive and now is awake and confused. She's contusion to her forehead, no other complaints. Heart rate is 106, blood pressure is 146/82, saturation is 94 on oxygen. We had her on 100%, and her respiratory rate is 18, and we have her boarded.
She sounds pretty stable at this point, but let's go ahead and move her over to the table. On my, make sure she's
Yep.
on my call. 1, 2, 3, over. All right, Shantara.